모듈로 들어갔어. 모듈가 있어. 모듈로 치죠.
Morning to everyone. I am Keva from Sunrise. Today I am going to present my EGM conference. This is my case summary. 26-year-old male with the chief complaint of division and his past medical history is not relevant and echocardiography show normal size, with normal ejection pressure is about 64% and normal eligibility attended by is about 9. This is very dedicated, and we can see as we begin this written script.
Yeah, I also curious on well as this people induction of idea.
Yes.
This little bit changed. No? Initial trials. With dominant maybe. After tachycardia, it changed to the S dominant.
First more for changing.
Right. Why?
So what kind of wearable did they use? So patches, two separate patches.
Yeah.
This is the initiation point, and this is the termination point.
But even before and after termination, QRSS is different, right?
Yes, yes, QRSS.
It's different to the standard 12 lead ECG. Likewise, the one we see the pragmatic as ECG axis a little change. But okay. And how's tachycardia initiation and termination?
This is the initiation point. I think the sinus big APC and the tachycardia boson. And then this is a termination point. Also,
It's not really APC.
yes, APC.
No.
Kind of this. Before starting tachycardia,
Before
is this APC black one? It's regular.
Yeah, still maybe still sinus.
And I wonder the red portion at the beginning of tachycardia.
Yeah.
Is there some preceded the POA or not?
This is, I think this is very small. POA.
It could be overlapped with previous preceding POA.
Yes.
Yeah.
Yeah.
What if it's POA, PR prolongation and tachycardia initiation? You can suspect what kind of tachycardia. Okay, what kind of tachycardia?
Maybe narrative.
Right.
Yes.
But I'm not sure it is the baseline is shaking. Anyway, during tachycardia, do you see any P wave overlap with P wave?
I think here is. I think here is big wave. Watching through the QRS.
Okay.
Then there is also big wave.
And very regular, but the before termination tachycardia cycles.
Yes.
Prolong. And do you see any P wave? The P wave at there?
I think this. Let's do this. I can see P wave. Here is P wave, and this let's be. I can see P wave. And then the tachycardia stuff.
And at the termination episode, do you see any retrograde P wave or any P wave overlapped with T wave?
I think this is P wave.
And the last beat?
The last beat also here.
Also there?
Yeah.
How do you know this P wave or the other acid change? You can compare the next beat. sinus rhythm. Okay. So sometimes it's difficult to differentiate the P wave overlapped with QRS complex. Then you can compare the next bit, sinus conducted normal QRS. Okay.
Okay.
So even though it is short period of tachycardia, you have to look for many important findings. Beginning of tachycardia, termination tachycardia, overlapped P wave, and the regularity, and especially when the tachycardia slows down, how does the P wave looks? Okay. Okay.
And then this is a clinic EKG for this patient. And in this ECG, you can see any pre-excitation. And also, this is the chest X-ray of this patient and localized moment. So we did the proposal about this study on December 9, 2025. This is our initial catheter positioning, MAO view and RAO view.
What spot?
And
You
then
say wrong timing.
this is the initial rhythm,
Oh,
normal sinus rhythm.
What?
Again, is about 1095 millisecond, AH is 86, HB is 65, QRS relation is about 103 millisecond. And
Why
then
HV interval so long?
stage is
HV interval 65 is abnormal, right? What is cutoff? 55. During pacing maneuver, you need to look for.
the signal is not that good
yes, yes, it is.
due to operators problem. So let's see.
Yeah. So nowadays I'm looking for those pressurized signal looks like his bundle very carefully at the area of his bundle recording area. So I discussed with Dr. Pang, some patient has triple his potential. Double his potential is quite common if you carefully observe that. Some patient is triple. Yeah. So his bundle is like a single bundle, we imagine, because the connection protein property and myocardial cellular gap junction array is different at the AV nodal area. So it's interesting. So sometimes if triple, if you measure the very early one, HB interval could be longer.
Okay.
So
And then this is, we did RBBCs in the milliseconds. The earliest retrograde ATO it's at 812 area.
this one, go back. So Zulja, where can you imagine where your ventricular catheter located? This is V pacing, right?
Yes, BBC.
Hmm?
I saw that before the ventricular, I saw the small potential.
No, during the basic EP study, ventricular pacing location affects the outcome of EP, right? Outflow tract pacing, apex pacing, middle septal pacing, all different. So how do you imagine your RV catheter location based on the electron, not by fluoroscope? If you step on the floor, it's easy to find out. But look at the QRS. The reason why we put the QRS at the top of the local electron is that is most important. Sophie, where do you pace now?
I think this is in the RV Apex.
Are they pets?
Yeah.
Why?
One because in the V1 it's entirely negative, which means the impulse is going from down upwards. And then from the stem to the H12, which H12 will be on the left. I don't know if there's a measurement, but it looks wide, which suggests to me that it's from the right and it's taking a while to retrievably go up the left. If it was RVOT pacing, that is a bit closer to the left. I'd expect a shorter distance between the stem and the H12.
Any different idea? Dr. Huang sent me kato. He cannot log in. Sorry about that.
Our
Any-
ABF,
Yeah.
positive.
Yeah.
Maybe positive.
Okay.
Yeah.
And lead one negative, you be mid-septum.
I think it's that was side.
Okay, show me the floral. We have answer.
The RAU and the LAU different time.
The same patient or different patient?
Same patient.
Same patient. But the RAO and LAO, the husband, the catheter location different.
So I'll be
Yeah.
considered this different.
Probably the high septum, because the ABF is positive. Yeah, you can determine the outflow high septal pacing and apical pacing based on the ABF cross direction.
And V1 is not for inferior or superior. We can get just V1 pacing LVB pattern. We can, if V1 is negative, does not mean it's coming from inferior to superior.
So if you guys should imagine where my catheter is, what we are doing. Okay, go ahead.
Okay. And then this is a vehicle cycle length. My RVP 280 milliseconds.
Why trust amplitude is shrinking? What happened? Okay.
It's not.
We did single AESD 680 to 7 seconds and we can find the decremental property is about 112 millisecond the same. And then tachycardia was induced by APC. And earliest site is H12. This is
Okay, this is very, very typical example of induction of ABRT.
yes.
Anybody can explain the mechanism of tachycardia beat by beat? As you told, the second bit is APC.
Yes.
APC from where? How do you know it is APC? No, second bit.
The earliest site is H19,
Mhm.
20.
Mhm.
It comes from
Someone wants to tell something.
Here the sinus node.
yes.
You have sinus node. Okay, so how do you know it is APC? Because sequence is very similar to the first one.
Yes.
How do you know? Polarity different, right? Even though activation sequence similar, electron shows different, right?
Yes.
H1920 and 1718, polarity is the opposite to the first beat.
Yes.
Okay, and coming down, the CS
Yes.
proximal is 19 similar, but 7-8 different, right?
Yes, yes, right.
And the CS activation sequence is a little different to the first one and second one.
Yes.
So what does it mean? Even though initial activation site is similar, but the activation pattern is different. So where is the inter-atrial conduction pathway? Normal inter-atrial conduction. Of course, in the atrium, there is no conduction pathway like the ventricular conduction tissue, but there is a myocardial preferential conduction. Number 1, Bachmann's bundle. Number 2, crista. Number 3, septal activation. Right? So even though their earliest activation site is similar to their probably high septum, high RA or high septum conduction change. So what does it mean? What does it mean? The CS activation change and polarity change. Some of electrical impulse coming down through the septum to left atrium. Okay. So you need to imagine when you're looking. Okay, let's move to the third one.
1, 2,
Two,
3.
Third one is also a little different,
Yeah.
but the CS electron polarity and activation sequence is quite similar.
That's
Right.
quite similar.
So I assume that this APC coming from nearby the high septal area, including the Bachmann's bundle. But why the second APC did not induce the tachycardia, but third one induced tachycardia?
Second one is conducted to normal conductions, fast pathway, and third one, when third one occurred, the fast pathway was the in refractory period. In refractory period, so it conducts through the slow pathway and PR prolongation. It make a time for the retrograde conduction through the accessory pathway.
Okay. So I don't know if the slow pathway conduction or the decremental property of AB node, but anyway, third APC prolonged the AB node conduction time. During that time, the accessory pathway is recovered from refractory period. Okay, then it came back to the accessory pathway retrograde. Okay. Any other comments about the mechanism? Okay, during tachycardia, how is the electron polarity? CS, look at the CS polarity.
Yes, CS polarity.
Activation
H3,
sequence different,
the
but the
sequence
polarity?
H3 is a little bit different. H3.
No. I mean the antigrade. Compare the antigrade and retrograde. CS polarity of antigrade conduction and retrograde conduction. Similar. I can see difference in the distal CS, right?
Yeah. Yes.
Proximal CS electron is a little wider, but the initial polarity is similar, right?
Yes.
So why is it? Because accessory pathway locates like this. Ventricle is more medial side, lateral side is more atrial side. So through the AB node conduction and retrograde conduction from more septal ventricle side more to more lateral atrial side. That's why the distal CS electron is significantly different between anterograde A signal and retrograde A signal. Okay. And right atrial activation looks not that different, but it is completely opposite to the first sinus beat. That one, and yeah, retrograde.
Yes.
So not only activation sequence, but also electrogram quality and polarity gives us many important information. Okay, so when you review the electron, oh, it's a ABRT, burn, all success. It's a good case, finish. Then you don't learn anymore. So please carefully observe the electron bit by bit. Then you can imagine how does it make a tachycardia. Okay, go ahead.
This is a dual EKG, very curious tachycardia at that time. You can see smoke T wave, yeah, after the QRS. Then this is the tachycardia. EGM, tachycardia cycle length is about 307. AH is 123, VA is 64 milliseconds, and QRS wave is about 88 milliseconds.
Okay, so let's discuss with this electron. The earliest VA interval, where is it? Earliest VA.
Earliest VA.
So which electrode? 1, 2, or 3, 4?
1, 2.
How about 3, 4?
Yes.
Which one is best side?
I think 1, 2.
1, 2.
Yeah,
Why? Why do you think?
Yeah.
How do you choose the right spot of ablation and accessory pathway conduction? How do you?
I don't understand. That's why
Just burn and check and burn mapping?
I had difficulty in this case.
Oh, really?
Yeah,
So where's the best position? CS electron A signal include both CS musculature and left atrial signal, right?
Yeah.
Usually left atrial signal shows a little far field, low amplitude. CS musculature fractionated high amplitude. The young EP doctors try to looking for the only big signal, okay? Because it's easy to see and prominent. But sometimes some patient has a little conduction gap between CS musculature and left atrial musculature. So that's why Dr. Huang always urged me to look for the pathway potential. Okay, pathway potential is tiny potential. So don't be tempted by this big atrial potential. Okay, so I see there's small fragment potential in H12. So I would like to look for the accessory pathway potential in that area. And of course, we need to search. And you see the polarity reversal between 1, 2, and 3, 4, right?
Right.
How about the 3, 4, and 5, 6?
The same.
Initial polarity is same,
Same,
right?
yes.
So I prefer to look for the accessory pathway potential nearby CS1, 2, and 3, 4. Okay. Don't be tempted by big atrial potential.
but I'm tempted by also the small CS musculature pinch. Things like pathway pinch. Or small fractionation.
그걸 찾아가면 된다니까.
But sometimes it is not successful
It's not successful.
when even I operate at a small
So you increase the power.
no,
of the irrigation.
no, so I'm not sure it's really pathway potential or just CS musculature
Yeah,
tension.
sometimes. But usually we see that during tachycardia, it is not easy to find it. But during deep pacing or sinus rhythm, if you But you need to compare the sinus rhythm A and B local electron shape and V pacing electron shape and to find down separate which one is local V, which one is local A, and which one is in between. So I learned it's like the Holy Father, Son, and Holy Spirit. So you need to target Holy Spirit, more potential. Yeah, I learned from Dr. Huang. Okay.
And we did his refractory BBC and B result was positive. So this is my summary. And we can see in this case, earliest refractory Atrial epidemic is at H12 during left phasing. And there is no BA decremental property during SPEST and narrow QRS tachycardia induced by APC. BA interval is more than 16 milliseconds and B reset by his refractory BBC. And so this is on C left lateral bypass track.
Okay, cool.
Okay.
Can you go back to one slide before? You mentioned about the B reset. So what does it mean, B reset? What kind of tachycardia do you want to differentiate at this moment?
In this picture, we show the possible means that we can exclude ABM action.
ABNRT,
Yes.
but the activation is apparently different ABNRT, right? And also
And also AT.
AT, yeah, AT from ligament Marshall or the mitral annulus tachycardia should be differentiated by B reset. Okay. And we discussed about where's the RB catheter location. So how different from the outflow pacing and apical pacing? Which one is better?
Tracing.
Why?
Why it's very close to that.
Close to where?
Close to the pathway. Accessory pathway.
RB outflow tract is close to accessory pathway? I don't believe so. Anybody can explain it?
Yeah, BOT is closer to the left side.
Mhm.
So since we're thinking this is a left-sided pathway, the concept of V reset is that you want to see if you are within the pathway to reset it. So because the RVOT is closer to the left, it will give a much more reliable picture if it's left lateral pathway compared to if you're down at the RV apex, which is further away from the reentry center.
Yeah, it is a little complicated, but how is it different to the left bundle and the right bundle? Right bundle branch is relatively well insulated and make a force pattern at the apical side. That's why there's difference of RV output pacing and the apical pacing. If you pace from the outflow tract, it captured to the septum and connect to the left bundle and easily coming to the accessory pathway area. But the RV apical pacing, because the right bundle is well insulated, you need the local cut capture and the right bundle and retrograde conduction to LV. So pathway is longer and slower. That's why there's difference. Okay. The main reason is right bundle is well insulated tissue. Okay. Very good. And any other maneuver you can differentiate the atrial tachycardia from ABRT utilizing left lateral pathway? Know the way? Dr. Om is expert to differential diagnosis with SVT. Please tell fellows every kind of differential maneuver.
In this case, we don't have to perform differential maneuver.
I know.
Because the electrogram sequence is clear. Yeah. For septal for differentiation, septal accessory pathway from ABNRT or septal AT, we have to perform differential maneuver. However, we reset or differential RV entrainment pacing is for differentiation between septal accessory pathway or ABNRT.
The reason why we need differential maneuver is some don't believe that this patient has only one tachycardia. Some patient has AV node reentry and the accessory pathway is bystander. So I think some fellows attend my procedure. I delivered a strong extra bit at the area of all this activation, A activation site, accessory pathway, and make a refractory period. And it will terminated tachycardia about the latest accessory pathway. Okay. Why?
Is this the evaluation catheter positioning? And also during evaluation catheter positioning,
What's that?
we can see this EGM. The earlier side is H12, and these two beads, and then contact ventricle and two beads. So actually, I'm not sure about this.
Yeah. You are smiling. Please tell us what happened.
This is the EGM during the ablation catheter position.
Yeah.
Can make a APC.
It's an echo.
It is
Oh. APC and conduct to the ventricle and echo beat.
Reasonable explanation. How come it is so regular?
like this.
So regular to beating.
Yes.
And there was a location of ablation catheter now? No. The base on EGM.
Oh, this one.
We are not plumber. We are the electrician.
Yes.
Where is the location? Theo?
The catheter induced the APC, then it could be near the H12, I mean the CS12.
I don't know if it's on the CS12, but based on the activation sequence, the ablation distal is all this one, right?
Yes.
And also it shows the prominent R wave, positive wave. That means the ablation catheter distal side, probably the original of this APC, right? And how's the amplitude of A signal and B signal?
Pretty safe.
It's the same.
Yes.
So it is on the mitral annulus area, but little apical side, atrial side, right? And we see the ablation proximal, ablation 3 or at the echo bit. That area echo bit, A signal local A is the earliest one, right?
Yes.
It is very close to the accessory pathway location. B12, I don't see the significant A signal, but the 3, 4, very close signal. I'm not sure, but if you blow it up, probably the potential is some small accessory pathway potential. I don't know, but potentially.
Maybe
Then-
last bit, maybe.
Last bit. Oh yeah, there's small potential. Still the signal is big, but there is small potential. Yeah, I guess that is accessory pathway potential. Then you see there, ablation distal is to atrial side, and you see the accessory potential on the 3, 4. How will you move your catheter? Pull back 3, 4. 3, 4 is target side.
Approximately.
Proximal is target side. Pull back. Then the distal tip will more atrial side, atrialized. Right? How will you?
Clockwise.
Hmm?
Clockwise.
Clockwise torque make your catheter tip more atrial side, move more atrial side. Problem is this distal tip is atrialized, right? So we need to move to more ventricular side, but more proximal side. How will you? How did you?
I tried to go counterclockwise a little bit.
Counterlize a little bit, then B signal is bigger.
Open the curve a little bit.
Open the curve or close curve? Open it. So annulus and the ablation catheter like it, like this, right? If you clockwise torque, it moves to more atrial side. Counterclockwise side, more ventricular side, right? But the contact is poorer if you counterclockwise torque. So 3, 4 is always one. So you need to pull back, but it could be more atrial side. So counterclockwise side and pull back and open the curve. That's the Dr. Kim did. Make sense? So I think nobody can. So remember, if you rotate, always when you ablate the left lateral bypass tract, rotate catheter and sheath simultaneously. Not only catheter, sheath catheter. If you rotate to clockwise torque, you move to the annual atrial side, counterclockwise side, ventricular side. Okay? And if it is proximally is the prop side, open the curve. Okay? More proximal side, deflect down. So imagine, and otherwise, when I give you the chance, you just floral and catheter jump out here and here, then I cannot give you more chance. Okay? Imagine, simulate in your brain. Okay, so yeah, that looks like the real passive potential.
Yeah.
Even though I don't like the AB amplitude ratio.
And this is that elevation.
What do you want to say?
Doubling with A, and so it can raise to 80.
What?
Which excludes AP. But we call it, this is ABC by catheter irrigation.
Oh, you suspected atrial tachycardia, combined atrial tachycardia. Yeah, some patient has both atrial tachycardia and ABR together. I also experienced several days ago, a few weeks ago. Yeah. Ligament to marshal is very close. So the atrial tachycardia coming from the same side. But it should exclude the catheter injection. What?
And then this is the pre-ablation signaling.
I don't want to criticize like Dr. Wang. Amplitude changing, right?
It was not stable.
Okay, anyway, Dr. Kim tried to look for the accessory pathway as much as he can. Okay, fine.
This is purine RF signaling.
AP. Oh, okay. Oh. Oh, converted spontaneously.
This is purine RF.
몇 번 방이야? Which room is this?
7.
I don't like this.
1.6.
Ablation 6. Room 6, the ablation signal became terrible.
This is
I
room
told
6.
the technician every time, but they are too busy. Okay, so
It's not VAD.
don't
Yeah.
think so. Non-sustained atrial tachycardia,
Something happened, so we cannot measure VAD.
and the tachycardia focus looks like a high septum again. But
Also,
because
alright. And we did LVPC and earlier segment show H12. And then this is the next ablation ketika ablation is a little bit higher than the previous one. And then this is pre-RF signal.
I like that skill,
Yes.
even though it is changing, keep changing. So how did you pace from LV?
Maybe.
Did you put one more catheter?
No ablation ketika.
No.
We use ablation.
I don't think so. Ablation catheter is mapping. This is ablation catheter pacing, but next one.
This one. This is
No. Yeah, this one. Your ablation catheter is mapping. And you pace from RV.
No, actually, I put high only RV pacing. There was some intermittent conduction by actually after I ablate sometime, few times. So to measure the conduction, I put quadripolar catheter through the same hole with the SL1 using the deflectable cheese catheter. Using one transseptal hole, I put quadripolar catheter and SL1 together.
So double transseptal function?
No, one hole.
I see.
I left wire only,
One puncture.
wire only, and
I see.
quadripolar first and SL1.
But the quadripolar catheter in LV is not supported by sheath.
Not supported by only catheter. it reveals the constant conduction by only using LV pacing. I can map and ablate this patient.
It's important message. Sometimes we cannot define the left side lateral pathway by LV pacing alone. In that case, LV pacing is very. So there is several possibility ways to do LV pacing. Dr. Kim is smart. He put the single hole and the quadripolar catheter inside the transeptal hole and LV piece. Other way is double transeptal puncture. The other one is CS and coronary vein, the LV piece. Okay. Oh, there's a double potential in H1 too.
Yeah.
In other words, he burnt a lot.
I did something. Yeah. Dissociation between CS musculature.
He burnt a lot.
Not a lot. Yes.
But the last bit is also still there's conduction. Last bit. Okay. So what happened? Eventually.
Again? Really?
This is evaluation or signal during RF.
Eventually, VAD.
Yes.
Yeah, we need to complain to the technician and nurses every time, even though they work overtime every day. But it is not allowed in the teaching hospital. Okay, so finally success.
Yes, finally success. The low EPC, the low injection, the low tachycardia. This is evaluation of signal. This is the final EGM of the RF.
Final ECG.
This is the final ECG.
Oh, there's Q wave in V5 and 6.
Yeah, and I would like to
Just
discuss the J wave.
Okay, V1, 2.
And lead 1, 2, 3 wave.
J-wave. It's quite common in young people, young male people.
Is it really okay? And
I think so.
naturally.
So-called early repolarization.
So the symptom in the family.
It appears after ablation?
Yeah.
Before ablation, no J wave?
In the I nothing that is J wave. J wave.
Yeah.
But there was no Q wave in V5, 6. And the last ECG shows Q wave in V5, 6. Probably a lot of burn.
Few times.
So that area sometimes especially overlapped with ligament marshal proximal insertion area. The posterolateral left posterolateral access pathway associated with atrial tachycardia or epicardial bypass tract, very hard to ablate. So can you share your experience, Dr.
Sorry.
Posterolateral accessory pathway, hard to ablate.
Do you mean the post-receptor?
Posterolateral. Same way, same this way.
Easy. I think detailed mapping is important during RD OT pacing. The during the RVOT pacing, we need to change the ventricular conduction direction from lateral to septal. We cannot achieve the LV conduction from lateral to septal, by very high RVOT pacing. Can you show me the during RV pacing? Electrogram during RV pacing. If we perform very high RVOT pacing, we can find out we can change the direction of LV conduction from lateral to medial. From this electrogram, the LV conduction is just septal to lateral. So we need to perform RVOT pacing more higher. Then we can find out more axillary pathway potential more easily.
Okay, so as I told you, please remember there's two layer CS electron base signal include atrial signal and the CS molecular signal. And in some patients with left posterolateral anterior pathway, very slanted, even sometimes from middle cardiac vein to posterolateral area, and also sometimes associated with ligament margin epicardial side. In those cases, very difficult to ablate. So you need to carefully observe the pathway potential, like Dr. mentioned, the differential pacing side, and carefully try to find out the accessory pathway potential. Okay, but sometimes it's very difficult to ablate. And so, what did you do? What is your next plan? If you try 2 or 3 times, you cannot ablate it, or the ablated but came back.
Most frequent reason is content. I will change. Sometimes I would like to change transality approach. If the contact, I feel contact is not yet sufficient. So even I did perfect mapping, I got potential. I feel contact is problem. I think I can change to transality.
How often do you try transaortic approach and such kind of stubborn bypass track?
Probably less than 5%. Very rarely.
For me, 0.
Actually, for me, 0. So actually, it's really easily. Yeah.
You know, in our view, mitral annulus plane and the coronary sinus is separated at distal part. Okay, so transaortic approach is valuable only the posterior septal bypass because it is very close to annulus and make a good contact. But make sure if your catheter is above mitral valve, there is no benefit. So if you want to make a real ablation by transaortic approach for the posterior septal bypass tract, make a curve, and your catheter should be beneath the mitral valve, make a good contact. It's very good contact. But for lateral pathway, the catheter, the contact is not that good. So transseptal is much easier to make a good contact to left lateral bypass tract because just torque, sheath support and torque and make a good contact to annulus. Difficult part is very high lateral accessory pathway. But high lateral accessory pathway is almost no atrial musculature, and if you rotate the sheath a little bit, it slips into the atrium very easily, and the stability is poor. In that case, the best way is push the sheath all the way to top and make a hockey stick, generating good content. So several weeks ago, I taught my fellows the left lateral bypass tray is the easiest bypass tray. Actually, the one patient Richard came back 2 times, but it was 3rd time ablation. You attended the case, and that patient has a very high lateral access pathway, and also associated with ligamental martial atrial tachycardia. So I used 3D map, but the EP procedure is same. Some patient is different, some patient difficult. We should be humble. Any other comment? No more question? Oh, sure.
The post-procedure ECG.
Yeah.
So comparing to the pre-procedure ECG,
Mhm.
this one shows some PR segment depressions, especially in the inferior lobes. And then the TP segment seems to slope down a bit.
Mhm.
And then in AVR, there's some PR elevation. Now, my question is, these are features of pericarditis, but given that the patient has just undergone ablation, would you just observe and wait it out as possible inflammatory reaction after the ablation? Or so just observing clinical symptoms, or you would need to take action on it?
Only the operator knows that.
No problem.
Yeah.
You didn't operate too much.
It's acceptable.
Yeah, especially after AF ablation, we check the ECG, every single patient, not only to watch the sinus rhythm, I always look for the potential pericarditis. But even the ECG shows us this kind of elevation. Patient doesn't have symptom. I always ask a patient, the patient complain chest tightness, deep inspiration. If it's pericardial pain, I use steroid. Otherwise, I don't use any anti-inflammatory drug, even though patient, the ECG shows that. Good question. Any other question? No? Okay. Thank you very much, and have a wonderful weekend. 황 선생님이 Dr. Wang had a snowstorm in Seattle, so he cannot connect the internet.